Alrighty, so let's talk about knee. Let's talk about knee effusions. Effusions are accumulation of fluid in the knee joint. The fluid could be just pus as a result of infection. It could be serous fluid, and it could be blood, or it could be blood, or both, I guess. Um, when you see serous if you have a meniscus tear, rheumatic or crystalline arthropathy, osteoarthritis, or a loose body hanging around. When you see blood, when you have trauma, fracture, dislocation, ligament tear, and posterolateral corner. Alright, so a quick way to categorize these is by their onset, because that's how they present. You could look at a rapid versus slow. Rapid onset is hemarthrosis, which means blood, and pyarthrosis, which means pus. So again, bloody types, you remember fracture, dislocation, all that jazz. What do you see here? You see surface ecchymosis. Do you see erythema? No. You see surface ecchymosis. And typically it's 3+. I have no idea what that refers to. Secondly, the second type was pyarthrosis. And in this case, you do see surface erythema. What else do you see? All the typical infection things, fever, chills, ESR, increase in WBC, white blood cell. So a patient comes in and they have a knee pain and you want to find out what it is. How do you do it? You palpate. First you palpate, you can diagnose a few things that way. Collateral problems you can diagnose. Osgood-Scatter's disease you can diagnose by palpating the tibial tuberosity. If tibial tuberosity is causing inflammation of the patellar ligaments, that's called Osgood-Scatter's. Also, you can diagnose tendonitis just by pure palpation. But what if the problem is more complicated? Let's say you have ACL tear. Well, you can do a Latchman's test or an anterior drawers test. In both cases, you pull the tibia anteriorly, and if it moves more than it should, then you know you have an ACL tear. Also, in ACL, you can have a pivot shift test, and you can simply observe that you have tenderness in the lateral capsule. The drawers test is also useful for PCL. So instead of pulling anteriorly, as you did with ACL, you just push the tibia posterior. And also similarly, you have SAG's test for PCL. And lastly, for PCL, you can just observe for valgus or valgus presence as you extend the knee. Alright, so then you have, what else can you have? You can have a patellar instability. How do you test for that? You kind of push, and if the patient shows apprehension, that's what you have. Patellofemoral syndrome, you compress patella. PL, posterolateral corner, you hold and extend the knee. You hold it in the posterolateral area, you extend it, and if you see hyperextension or lateral rotation, then you have posterolateral corner. Alright, so that's all for the knee. Also, lastly, if you have ITB syndrome, like we said, you could do Ober's test or ITB stress test. Alright, so let's say you have a fractured knee. You could fracture the femoral condyle, tibial plateau, or the patella itself. Alright, so now let's say, how do you decide if an x-ray is necessary? Listen to Ottawa. Ottawa says 55 years old, can't bend the knee or can't take 4 steps, or you just have tenderness on the fibula, on the patella. Alright, so that's what Ottawa says. If Ottawa is positive, or if you meet Ottawa criteria, then do x-ray. Alright, so the other scenario is knee dislocation. It could be a result of trauma, as with the hip dislocation. And you also want to do an emergent reduction to minimize complications like vascular compromise or joint instability. Alright, so instability. It could be a result of subluxation or dislocation. Presents usually on the lateral side. Usually it's a female. Usually she had an accident while the quad was firing as the hip was externally rotated. Knee was in valgus position. So on the exam you see a sort of less of a patellar prominence, possible effusions around the knee. You image it, you give him a brace, and if that doesn't work, you do surgery. Alright, going back to ACL and the Lashman's test. ACL is caused by pivoting on a planted foot, and once it's torn, you see inflammation, instability, and some mechanical locking of the knee. You want to stabilize it and you want to protect it, so you reduce activity and you put a brace on. And if you want to prevent osteoarthritis, you need surgery. Alright, so other problems are patellar tendon rupture and meniscal tear. And for these, you need to know the mechanism of injury, presentation, physical exam, imaging, treatment, and all that jazz. Unfortunately, I don't have them on the PowerPoint, so you'd have to look them up. Alright, so tendonitis, bursitis of the knee. Think of it in very general terms, just inflammation. Put a brace on and ice it, and don't do anything crazy. Alright, so patellofemoral syndrome, aka chondromalacia patella. What puts you at risk? Increased Q angle if you're a woman. Knock-kneed, I don't know what that is. Flat feet, improper shoes, and obesity. So these are the risk factors, and how do you treat it? You strengthen the quads. You rarely do surgery. Alright, so long distance runners get runner's knee, aka IT band tendonitis. It presents as snapping and pain on the lateral part of the knee. You give him NSAIDs, you tell him to stop running and ice it, and if it doesn't get better, give him injections. Alright, so then you have the Baker's cyst. Its underlying cause could be any sort of inflammation in the knee, arthritis, trauma, tear, anything like that. It presents as a palpable mass behind the knee, so the synovial sac has sort of traveled to the popliteal area. How do you treat it? You don't. You treat it only if it's symptomatic and if it's bothersome. You can aspirate it. You can sort of use steroid injections. You can you can do injections for inflammation, just like everything else, you know, and you can use NSAIDs and yeah, all that jazz. Yeah, and you do an MRI because you don't see fluid on X-ray. What else can I tell you? Presentation, I am not sure. Probably a little pain, palpable, yeah. Alright, knee osteoarthritis is degeneration of the joints, knee joints. It's important because of the cartilage part. Once that's gone, it's bone on bone. It's common in women, usually above 40, presents with pain, stiffness, and effusion, that sort of jazz. Decreased range of motion, and possible Baker's cyst. Alright, so what causes it? Trauma, instability, ligament instability, possible obesity, arthritis, for example, could be an underlying cause. It usually is detected on the X-ray as you know, those osteophyte formation on the margins of the joints, or the space narrowing is also very diagnostic. So how do you treat it? You treat inflammation. You either do NSAIDs or ibuprofen, or you do injections, or you do weight loss or hydrotherapy and physical therapy. If nothing works, you do a knee replacement. Alright, so quick overview of some standard treatments. You have meniscus, decrease ambulation and do arthroscopy. For ACL, you increase range of motion, you improve quad strength. It's possible that you need open reconstruction. For PCL, you don't repair it. For collateral ligament, you don't repair it. For fracture, you stabilize it with a brace or a cast. For posterior lateral corner, again, you do an open reconstruction. For infections, treat them like an infection, antibiotics, and you do a surgical referral. And lastly, for tendonitis and strains, you do rehab, physical therapy, ice heat, and blah blah.